Hello, I am Dr. Ajay Padmanabhan, Consultant Critical Care in Apollo Main Hospital. I will be talking about management of VAP or ventilator-associated pneumonia. In this presentation, we are going to be specifically looking at VAP or ventilator-associated pneumonia. VAP differs from HAP. HAP or hospital-acquired pneumonia are infections that occur in patients more than 48 hours after admission in the hospital when the infection has not been present at the time of admission or incubating at the time of admission. VAP differs in that it is specifically related to the process of intubation and mechanical ventilation. As defined by the IDSA, VAP is a pneumonia that occurs more than 48 hours after admission in patients who have been initiated on mechanical ventilation. The pathophysiology of VAP is related to the number and virulence of the microorganisms entering the lower respiratory tract. In severely ill patients, the most common reason is microaspiration of microorganisms that have colonized the oropharyngeal tract of the patients. In severely ill ventilated patients, microorganisms from the hospital environment will colonize the oropharyngeal tract of ventilated patients within the first 48 hours. This colonization is made worse by direct contact between the contaminated environment and the respiratory devices. Disposable tubings like endotracheal tubes get contaminated during routine nursing as well as from the contaminated hands of the healthcare personnel. The most common microorganisms causing ventilator-associated pneumonia are usually gram-negative bacteria like E. coli, Klebsiella, Acinetobacter, but also gram-positive cocci like Staphylococcus aureus. Risk factors for VAP are both host-related and device-related. The most common risk factors are the severity of the illness itself, like ARDS, patients of older age, unconsciousness, surgeries that involve the chest and abdomen, multiple trauma are some of the common risk factors for increased incidence of VAP. Agents that increase the gastric pH, such as proton pump inhibitors and H2 receptor blockers, commonly used in the ICU, also are associated with increased incidence of VAP. There are some factors which result in increased incidence of MDR VAP. These are use of IV antibiotics in the previous 90 days prior to this admission, septic shock at the time of VAP, need for renal replacement therapy, and ARDS are associated with increased incidence of MDR VAP. Like with other nosocomial infections, for the prevention of VAP, we use care bundles. Care bundles are a set of interventions that are evidence-based that when implemented together results in better outcomes than when implemented individually. Following care bundles ensures that all the interventions are applied uniformly to all the patients at all times. These are the basic components of a VAP bundle. Each of this component is important as each one has shown evidence that they not only reduce the incidence of VAP but also improve hospital outcomes. First, use non-invasive ventilator whenever feasible and try to avoid intubations. If non-invasive ventilation cannot be used and intubation is required, I suggest using the following components. First, interrupt sedation. Avoid continuous sedation whenever feasible. Try spontaneously awakening the patient. Next, try to give spontaneous breathing trials in the awakened patient in an attempt to liberate the patient from mechanical ventilation and extubate the patient. Next, change the ventilator circuit tubings only when they are visibly soiled or contaminated. This makes sure that the handling of the circuits is decreased. Head and elevation to an angle of at least 30 to 45 degrees is important in reducing the microaspiration of oral flora. Using specially designed endotracheal tubes which have subglottic drainage, which will drain the secretions that have been pulled above the endotracheal tube cuff and hence aspirating into the lungs also helps. Early mobilization and physiotherapy and exercise also helps in preventing VAP. Finally, often forgotten and the most important is ensuring proper hand hygiene among the healthcare personnel. There are some special approaches which could help by reducing the incidence of VAP but may not affect the overall outcomes. These are regular oral care with chlorhexidine mouthwashes, mechanical toothbrushing, selective digestive decontamination of the oral tract by application of non-absorbable antibiotics administered orally or enterally, maintaining the endotracheal tube cuff pressures at 20 to 30 centimeters of water and monitoring it regularly, and the use of closed suctioning systems. There are some practices which were commonly used but are no longer recommended because neither do they reduce the incidence of VAP or the overall outcomes. These are monitoring the gastric residual volumes, silver-coated endotracheal tubes, early tracheostomy, early parenteral nutrition. These practices are no longer recommended, and some practices such as stress ulcer prophylaxis could even be harmful. The diagnosis of VAP is by a combination of non-specific factors. First, there is a clinical suspicion of VAP is raised when there is onset of a new infiltrate in the X-ray or CT scan. When clinical suspicion is raised, we also look for other clinical features such as fever, leukocytosis, increased secretions, decreased oxygenation, and increased respiratory rate. When there is a clinical suspicion, the next step is to sample the lower respiratory tract. The sampling of the lower respiratory tract is supported with blood cultures. Following sampling, empiric antibiotics should be given. The sampling of the lower respiratory tract can be done both non-invasively and invasively. Non-invasively by using a mucus aspirator and tracheal suctioning, and invasively by using a bronchoscopy. Studies have shown that both are effective and the use is based on local practices. The cultures that need to be sent can be done semi-quantitatively or quantitatively. Gram stain is also sent. Coming to the treatment of VAP is primarily with antibiotics. The antibiotics are given empirically. The choice of empiric antibiotics depends on the resident flora in the patient, resistance rates in the ICU, recent antibiotic use, presence of comorbid illness, the severity of the illness, and the local antibiogram. When clinical VAP is suspected, empiric antibiotics needs to be initiated. For this, I will be referring to the IDSA guidelines of 2016. First thing to see is if there are risk factors for MDR infections. Factors such as prior antibiotic exposure, need for renal replacement therapy, ARDS, and septic shock at the time of VAP are risk factors for MDR infection. If these are present, the patient should receive maximal antibiotic coverage. This includes 2 agents which will cover Pseudomonas of different classes, such as an anti-pseudomonal penicillin, such as piperacillin, and another anti-pseudomonal agent of a different class, such as aminoglycoside, along with an agent which will cover MRSA, such as vancomycin, needs to be given. If these risk factors for MDR are not present, the next thing to look for is if there is presence of plenty of GNB in the smears and there is presence of lung disease. If there is presence of previous lung disease and plenty of GNB in the smear, the treatment should include 2 agents which will cover Pseudomonas of different classes, and this should also cover MSSA. An agent such as piperacillin tazobactam is perfect for this. If there is no lung disease and no GNB in the smears, then a lesser coverage with 1 anti-pseudomonal agent which has MSSA coverage also is required. If the hospital has plenty of MRSA prevalence, that is more than 10 to 20% prevalence of MRSA isolates, then that means that the empiric coverage should also include an agent which will cover MRSA, such as vancomycin. Once a microbial diagnosis is made, the antibiotics ideally need to be tailored as per the microbial susceptibility and ideally de-escalated based on the clinical response and the culture reports. Ideally, the duration of treatment is for 7 days, but the treatment duration could be extended based on the clinical response, radiological recovery, and lab parameters. And importantly, Antimicrobial stewardship is essential to prevent the emergence of extremely drug-resistant strains in the future. I hope this presentation was helpful and would help in the future to reduce the incidence of hospital-acquired infections. Thank you.